Children, I don't treat children, but if we were to talk about chronic cough in children, you should look for specific cough pointers in children, because cough reflex is significantly matured only in early childhood, and it is the respiratory structure itself matures from infancy to adulthood. So they may have limited cognitive function and ability to self-express, and therefore the cough in children needs specific cough pointers to diagnose. So in history, what are the cough pointers? The most common cause is protracted bacterial bronchitis if a patient presents with productive cough. Hemoptysis, patient may present with patients with infections like TB. ILD is not that common in children, but bronchiectasis, cystic fibrosis, these are the common causes where they may present with wheezing, productive cough, and hemoptysis. And recurrent pneumonia may be another cause. In these children, episodes of choking, please look for any evidence of inhaled retained foreign body. So these are pointers in the history. Examination-wise, in bronchiectasis, patients may have clubbing of the fingers. They may have chest wall abnormality, which points towards a neuromuscular disease or lung disease, and routine investigations and abnormal chest X-ray and spirometry. Spirometry is very difficult to do in children, and nowadays we have iOS, which actually helps in diagnosing a lot of patients with obstructive airways disease, because it is very, very simple. Impulse oscillometry is a very simple way of identifying patients who have, younger patients who have obstructive airways disease, because spirometry is difficult to do for children below a certain age. So in this study published in 2012 in Chest, protracted bacterial bronchitis was found to be the most common cause in children from 0 to 12 years of age, asthma being the close second, with bronchiectasis and other causes like non-specific causes and tracheomalacia being the lesser common causes, and pertussis and aspiration not far behind. So when you're approaching a chronic cough in children, you look for specific cough pointers. If there is non-specific wet cough, then you look for a provisional diagnosis of protracted bacterial bronchitis and give them antibiotics at least for 2 weeks. If they do not improve, reassess. If they improve, then it is likely to be a protracted bacterial bronchitis, and you reassess them again. In non-specific dry cough, you wait and watch for 2 weeks. If there is no improvement, then you give them a budesonide inhaler after doing an iOS, if it is possible, which is impulse oscillometry, or an empirical treatment for 2 to 4 weeks. If they do not improve, you reassess. If they improve, then it is likely that they are a wheezy child or have a tendency for asthma, and you continue to follow them up. So there are new drugs that are available for desensitization through the use of antagonists such as capsaicin, which show a promising therapeutic strategy. But how it is going to pan out, we really don't know. At the moment, most people think that cough suppressants such as dextromethorphan, etc., are good things for cough. But please remember, cough is only a symptom. Much effort was devoted to the development of blockers of the nociceptors, mainly transient receptor potential receptors, responsible for irritant sensation, leading to tickles that precede cough. So while effective in animal models, these agents have unfortunately failed in the clinic. The first antagonist, cough antagonist, which is gefapixant, has been studied in patients with resolution in the majority, and let's look forward to this. Other compounds are still there, but we still don't have anything that effectively stops or improves the cough, because it is just a symptom. It reflects very varied number of diseases that cause it, and you really need to treat the condition that is causing the cough if you need to get rid of the cough. But we do feel the pinch when it comes to diseases like interstitial lung disease, where cough is a very, very, very debilitating symptom. So recommendations and research gaps are significant, and obviously a lot of more cohort studies are required to look at the true prevalence of chronic cough in the population, and studies of overlap between respiratory diseases and chronic cough are urgently needed. Thank you very much. That's all that I have to say. This is just a slice of what we would like to talk about in cough, because it is a symptom that is so common yet so poorly understood and followed up. Therefore, following a protocol of diagnostics will help you identify the phenotype of cough that your patient is presenting with and help you with with treating them and actually helping them get rid of the cough. Thank you very much.